This is Casey Glass, and I'm going to give you a quick overview of death certification for physicians practicing in a hospital setting. And so in particular, this would apply to our emergency medicine residency staff as well as other physicians practicing in a hospital setting. So one of the great challenges of being a house officer in a teaching hospital is attending to deaths. Deaths in the hospital, unfortunately, are common as people come to the hospital in often poor states of health and because of their chronic illnesses. And so it's a guarantee that you're going to attend to the deaths of patients. And in many cases, you may be required to complete a death certification. The death certification can be kind of troublesome, especially if you're not familiar with it. It is really a legal document that we are asked to complete, and so the language that you use in that document carries a certain weight and has to be done in a particular fashion in order to be compliant. And if you don't take care to do it correctly, you can cause some problems for the patient's family in terms of having the body released for burial, and so it's important to complete that correctly. Important things to note are that death certificates are a state-specific thing, and so the way we certify deaths in North Carolina and the death certificate that we have in North Carolina is going to be particular to North Carolina, and it will not be necessarily the same in other states, even states that surround us. There may be different laws regarding who can certify a death. Also, your healthcare organization may have policies regarding who can certify a death, and so you should be aware of those things. For example, here at the Wake Forest Health System, the person responsible for certifying the death is the attending physician or their delegate at the time of the patient's death. And so if the patient dies in the emergency department, that would fall to the emergency department physician. If the patient dies in a hospital setting, that would fall to the inpatient physician, and so on. So let's take a case for a minute. You're an intern on an overnight call when a patient who was on palliative care expires. You're asked by the nursing staff to come to the bedside to certify the patient's death. You go to the bedside, examine the patient. Indeed, they have passed. You notice there's no cardiac activity on the monitor. The patient's not making any respiratory effort. You write a short note in the chart that says, yes, you came to the bedside after a nurse call and the patient has expired, and then leave to go home. You're sleeping during the day when the phone rings and the nurse for the hospital is calling to try to get you to complete the death certificate so the body can be released to the funeral home. You're sure that probably that's not your responsibility, but nonetheless, they've got you on the phone and you're wondering kind of what to do. So one of the big challenges is that we don't often teach the actual process of certifying a patient's death. There are several components to this. Most importantly, the patient needs an exam to verify that they are in fact deceased. That exam needs to be documented in the chart so that someone else who was to look at it could see that a complete exam was done and what the findings were that documented this patient had died. Many times it will be necessary to notify the medical examiner to determine if this patient should have an investigation into their death. You also need to notify the family. Many teaching institutions offer an autopsy even if the medical examiner does not want to do one. You should be familiar with your own institution's policies around that. Lastly, you need to complete the death certificate, and it is usually good manners to also notify the patient's primary care physician that their patient has died. There often is a lot of confusion and concern about discussing organ donation, especially given the overall need for organs in our healthcare system. Most institutions have a fairly specific scripted manner of discussing organ donation with families, and it is usually not the role of a house officer or even the physician staff to really discuss organ donation with the family. So I'd encourage you that unless you are specifically directed to discuss organ donation with the family of a deceased patient, to not do that. In our institution, there's specific nursing scripting and notification of our organ procurement service, who has a very detailed discussion with the family at the right time about organ donation. So let's discuss the exam components of the death certification. So what do you have to do at the bedside in order to document that a patient has died? Well, a couple easy things include documenting their pupillary reflex to light or the lack thereof. Likewise, it's easy to document a corneal reflex. Technically, you need to Note the absence of heart sounds for a total of 1 minute, because it may be the case the patient is profoundly bradycardic, and over the course of even 6 or 10 seconds, there may not be a heartbeat to listen to. Also, you should document the absence of spontaneous respirations and the absence of response to painful stimuli. Altogether, that's sufficient to document that the patient has died. Part of your documentation of the patient's death will be noting the time of death. It's important to make this consistent across the medical record, and almost always we're going to use a hospital timekeeping device for this. So you may use the clock on the electronic chart, you may use the clock in the patient's room. You should discuss that the time of death with the nursing staff and make sure that you are using the same time of death in your notation. Otherwise, that causes a discrepancy that can be hard to resolve later. Many cases of death that occur in the hospital setting may be necessary for further investigation by the medical examiner. States often have laws regarding which cases have to necessarily be seen by a medical examiner, and then if there's any concern about the cause of death being non-accidental or non-natural, those would be cases to refer to the medical examiner. For patients who present to the emergency department, there's a special concern, as we often don't have very much history about the patient and are not familiar really with their chronic medical problems outside of what might be recorded in the chart, and so we more often will contact the medical examiner to get their input on those cases. In North Carolina, all traumatic deaths are medical examiner cases regardless of how much time has passed since the actual trauma. So, for example, if you had a patient who became a quadriplegic due to an accident and then died later of a healthcare-associated pneumonia, which was in turn due to their quadriplegia, that would be a medical examiner case even though their cause of death was from a medical cause. When you don't have a medical examiner type case, those deaths are termed natural in the sense that it was an organic disease that caused the patient's death and not the actions of another human being. Many institutions, again, make an autopsy available to families, even if the medical examiner declines to take the case for further investigation. You have to be very careful about how you offer an autopsy to a family. It's often good to script that or role play that with your attending staff prior to actually discussing it with the family, but you do need to know if this is going to occur before you complete the death certificate. The death certificate really is the most challenging thing about certifying a patient's death. And it's not so much that it's hard to complete, it's more that it has to be completed in a very specific way for it to be a sufficiently adequate legal document for terms of filing the patient's death and getting the body released to the coroner. This is the official record of why a patient died, and unfortunately that often intimidates house staff and even attending staff with regards to completing it. They're very concerned that if they were to put down something in error, that this would be a big problem. But as we're going to discuss, the death certificate does not require certainty, just your best educated guess about the cause of the patient's death. These are ultimately filed with the CDC for national statistics and with your state Department of Statistics. And again, if you don't complete it correctly, that can cause a delay in the release of the body. And we do not complete it at all if the medical examiner or pathologists are taking the body for further investigation. So the process for certifying a death goes something like this, and following the death certificate through its channels, you're going to complete it at the bedside, and then usually it'll go to the funeral home, and the funeral director is going to add biographical information about next of kin, mother, father, that sort of thing. Then it'll get filed with your county, who are going to review it for accuracy with the records that they have, and then it'll go to the state health department, where they'll keep a copy of it, and then it'll finally go to the CDC for national records keeping. And this is what our North Carolina state document looks like. It's very complicated. There's lots of boxes and check boxes, and it's really, really intimidating. But in fact, we only really need to deal with the bottom half of it. And even less than that, we really only need to deal with this kind of middle bottom third piece of it. And so we're going to look at that in a little bit more detail. So let's just think for a minute about this patient. So we have a kind of later middle-aged woman, early elderly woman, 68-year-old lady admitted to the ICU with some shortness of breath and chest pain that does not get better with nitroglycerin. She gets non-STEMI and has elevated troponins with concern for this non-STEMI myocardial infarction. She then develops some AV block and gets a pacemaker, but she goes on to volume overload. During her seventh hospital day, she starts to walk and gets worse pain and shortness of breath. At that point, she has the diagnosis of acute PE and start on heparin. An hour after that, she becomes unresponsive and is unable to be resuscitated. So looking at that complicated hospital course, you may be pulling your hair out with regards to trying to complete this death certificate. It just seems like too much information. But we're going to go through the different pieces of our section of the death certificate, and I'll show you that it's really not all that challenging. You just need to kind of simplify it down and accept the fact that you're going to have to make some educated guesses here and there. So there's a couple big pieces of this middle bottom third section that we're looking at that we have to deal with. One of them is the actual cause of death. The next piece is what other medical conditions the patient had that might have contributed to that cause of death. And then the very last piece is the medical examiner involvement. The other things are fairly self-explanatory, such as the time of death and was an autopsy performed, etc. Before you get started writing on a death certificate, you need to know that you can only do it in black ink, and you may never use abbreviations. And so everything has to be spelled out specifically. So for example, writing AMI for acute myocardial infarction is not acceptable. You would have to actually write out acute myocardial infarction. The cause of death is the section of the death certificate that probably gives those completing it the most heartburn. Causes of death are really most probable. So this is, after the event, your most reasonable estimation as to why the patient died. The other thing is that it is a disease process, not a physiologic state. So for example, to write cardiac arrest as a cause of death is incorrect. Cardiac arrest is a physiologic state. The patient's heart is stopped. But there's some disease process that led to the arrest, and that would be the cause of death. You also need to describe the time between when the patient became ill with that particular illness and when they died. And it is okay to be general with regards to that time if you don't know it. So this other medical conditions part is a place to list the patient's significant medical conditions that may have not contributed directly to this patient's demise, but are factors in determining their overall state of health and their ability to survive their medical illness. You don't have to include all of their medical conditions, just ones that you think may have contributed to their inability to survive whatever this final illness was. And then lastly, you need to document whether or not the medical examiner was called and if they took the case. When you're completing the form, if you make an error, you have to start all over on a new form. Because house officers and attending physicians honestly are the ones who most often make mistakes with the form, usually you'll be the first one to fill it out after the person who handles decedent affairs in your institution has put the patient's name on it. That may actually be a charge nurse on your unit. It may be a specific nurse or other decedent affairs officer in the hospital who brings it to you with the patient's name on it. But oftentimes you're working with a mostly blank form except for the patient's name. If you do make an error, do not try to cross out your error and continue. It is at that point an ineligible form and they are going to find you to complete another. It's much better just to find them and get a new one and complete it at the same time. And lastly, don't get upset if your decedent affairs office calls you to complete another death certificate because the one that you had already finished got messed up by someone else. It happens sometimes. Everybody makes mistakes. And again, this form is not final until it's filled out in its entirety correctly without any errors. So let's go ahead and give it a shot here. We have a gentleman who comes into the hospital with some sort of abdominal infection, and he has peritonitis and dies. And it turns out that he had come into the hospital 2 weeks ago after being stabbed in the belly. He also has some peripheral vascular disease as well as obesity. So let's go ahead and try to fill this out. And we'll take a look at it here. You may have some, maybe primary cause of death is peritonitis. But wait, this guy died from trauma. So that's a medical examiner case. So we're not going to fill that out. If there's trauma involved, even if the traumatic event itself did not kill him, that's a medical examiner case. All right, let's try again for real. So there is an elderly woman who dies of sepsis in the ICU. She began her hospital stay with cystitis, and she has some comorbid medical conditions. So in terms of the thing that actually killed her, it was severe sepsis. So it's not cardiac arrest, it's not respiratory failure, it's severe sepsis. And we can actually see from the chart that this happened over the course of 2 days. Before that, she had bacterial cystitis, and that lasted for 8 days before she died. And then she also has these other chronic medical conditions, which probably contributed to her inability to fight off this final infection. Let's try another case. We have a middle-aged gentleman who dies of respiratory failure with a history of cystic fibrosis. He's been anemic, malnourished, and had a lung transplant a year ago. So this looks like a pretty complicated history, but again, abstracting it out onto the death certificate is not too hard. So the actual cause of death is not respiratory failure, it's bacterial pneumonia, the actual disease process that caused his lungs to fail. And we know from the chart that that has been going on for about 8 days. Now, if we looked at the history and physical and found out he'd been ill for 4 days prior to that, then the actual time to death would be 12 days. There's a history of cystic fibrosis. It may be hard to look at the chart and know when that was finally diagnosed, but we know that you're born with it. So in fact, he has the duration there will be 40 years. And then these other contributing medical conditions may have contributed to the death. We may put lung transplant on there as well. You'll have to make a judgment call about that. There's a 55-year-old who dies in the ED because of probable cardiac arrhythmia. And we are guessing that because he has a history of ischemic heart disease with the AICD placed. And based on the history, he had a sudden loss of consciousness and arrest and was not able to be resuscitated. So we are going to make our most probable estimation that this patient died of ventricular arrhythmia. Again, there's no way to confirm that, but that's not what the death certificate requires. It requires our best estimate as to the cause of death. And we don't know exactly when he went down, but let's say it was minutes prior to his death being declared. And the contributing factor would be ischemic cardiomyopathy. And he's had that for years. We're not sure exactly how long because we don't have the records that describe that. And coronary artery disease contributed to his ischemic cardiomyopathy, and that also is years. And then he has these other contributing medical conditions, which may not have directly caused his death, but contributed to the disease progression. Here's another interesting case. A 67-year-old patient comes in for a cholecystectomy and has a small bowel injury during surgery and develops peritonitis in the ICU and ultimately dies. And again, this actually is an ME case. So the big picture, if a person caused the conditions that led to the patient's death, whether accidental or intentionally, traumatized the patient, that's going to be a medical examiner case. And here's our last one. We have a 60-year-old with cirrhosis, multiple medical problems including drug abuse. The patient comes into the ED, gets admitted to the hospital with acute renal failure, develops hypotension, and then ultimately dies. And cultures grow out gram-positive cocci. So we want to be as specific as we can with the death certificate, and in this case we can say that the patient seemed to die of severe sepsis, and specifically gram-positive cocci sepsis. And then has these other contributing factors, so SBP was probably the original infection, liver cirrhosis led to the SBP, alcoholism led to the liver cirrhosis, and then these other contributing causes. This, of course, has been a brief overview of death certificates, although I hope it is helpful in terms of demystifying the death certificate and the death certification process. There are some really great resources online. The Duke Decedent Care course is similar to this lecture, except for it gives some more practical, hands-on type scenarios to work through. The CDC also has some links about certifying deaths. The short version, that is the second link, is a quick look at their version of the death certificate, and it also describes how to describe medical conditions in the death certificate without referring to actual physical states like cardiac arrest. And North Carolina's Vital Records also has a website where you can work through the North Carolina version of the death certificate as a tutorial, so you can get some more experience with that. If you have any additional questions, you can email me at cglass, cglass, at wakehealth.edu. And thank you very much for your time.